Hello, my name is Georga-Lee and today I will be presenting a video analysis on running. To begin, I will discuss the body segments provided in 4 still images taken from a running movement, which include the running phases in both sagittal and frontal views, and display the takeoff phase, mid-swing, and initial contact. Then I will move on to speak about the effects that running technique has on performance. Next, I will discuss a common injury related to running, and finally, how the injury affects the running movement. In this sagittal view of a running movement, we can see that this image represents the initial contact phase of running as the right heel is making initial ground contact. There is external rotation of the right shoulder as the right arm moves posteriorly. Slight elbow flexion is maintained as the right arm extends posteriorly. The left elbow is flexed as the left forearm is raised almost parallel with the floor. The palms are facing medially due to the internal rotation of the forearms. The left palm is moving medially as it adducts anteriorly, whilst the right arm is in a more lateral position as it slightly abducts and moves posteriorly. Moving down the body, the right hip is extended and internally rotated as the right leg moves in an anterior direction and the runner is propelled forward. The right leg begins to extend, however, slight flexion in the right knee is maintained to allow for protection of joints on impact. The right foot is dorsiflexed, allowing the runner's heel to make initial contact with the ground, which also causes ankle flexion. The left knee is flexed as it moves in a posterior direction. The left foot is elevated and in a plantar flexed position with the runner's toes pointing towards the floor, causing the left ankle to extend. The left pelvis is internally rotated, whilst the left hip is externally rotated, and the right pelvis is externally rotated, whilst the right hip is internally rotated. The counter rotation of the hips and pelvis allow for balance and overall momentum in the running movement. This image also demonstrates the contralateral movement of the arms relative to the legs. This next image shows a takeoff position where the right leg is propelling the runner forward by pushing force off the ground. Flexion can be seen in both elbows. The right arm is moving anteriorly and medially, whilst the left is moving in a posterior direction. The right shoulder is beginning to internally rotate as the runner moves the right arm anteriorly. The palms are facing medially due to the internal rotation of the forearms. The right knee and hip are extended extended posteriorly, pushing the runner forward. Both feet are plantar flexed, with the right foot on the floor and the left foot elevated. The plantar flexion in the feet also allows both ankle joints to extend. The left leg is flexed anteriorly, flexing both the hip and knee joint. The left hip is internally rotated, whilst the left pelvis is externally rotated, and the right hip is externally rotated, whilst the right pelvis is internally rotated. The trunk is tilted slightly forward. This third image shows a mid-swing position. The runner's shoulder does not appear to be rotated, as the arm is close to the anatomical position. However, the forearm is internally rotated, and there is a slight flex at the elbow. The right hip and knee joint are flexed, and the right foot is elevated and plantar flexed. The right ankle is moderately extended due to the plantar flexion of the foot. The left leg is almost fully extended, extending at both the hip and knee joints. However, there is a slight flex in the knee. The left foot is flat on the floor, and the left ankle is slightly flexed due to the slight flex in the knee joint. In this position, the hips and pelvis do not appear to be rotating, as both legs are parallel down to the knee joint. Looking at this final image, we can see external rotation of the right shoulder as the right arm is moving posteriorly, at the same time that the left leg is moving posteriorly. The left shoulder is internally rotated as the left arm moves in an anterior direction, following the direction of the right leg. Both elbows are flexed, however, the right is more extended, with only a slight flex at the elbow. The palms are facing medially due to the internal rotation of the forearm. The left knee is flexed, causing the left foot to be elevated with the tibia parallel to the floor. The left foot is plantar flexed as the toes are pointing inferiorly, allowing for ankle extension. The right leg is almost fully extended, however, a slight flex remains at the knee joint. The right foot is dorsiflexed, allowing the heel to contact the ground before the toes and the right ankle to flex. It appears that the right foot is slightly supinated as the lateral aspect of the foot is contacting the ground first. The right hip is internally rotated to maintain stability and soften the impact of the anterior leg, whilst the posterior leg is elevated. The right pelvis is externally rotated and the left pelvis is internally rotated. The left hip is externally rotated as the left leg moves posteriorly. Running depends on sustained aerobic energy production that is used for forward movement. Due to the freedom of movement in running, individuals have the opportunity to use a variety of techniques to achieve this forward motion. Variation in technique can have positive or negative impacts on running performance, and in extreme cases can lead to injury. It was found that running technique was responsible for 31% of variance in running performance. As an example, it was found that greater foot angles at initial ground contact were negatively related to running performance. Smaller foot angles contribute to greater hip and knee movement and are associated with greater running performance. Furthermore, vertical displacement of the pelvis during contact with the ground was strongly related to performance. Improved performance was found when vertical displacement of the pelvis was reduced during ground contact. Incorrect running technique can lead to injury due to increased strain on joints, muscles, and tendons. It was found that less contralateral pelvic rotation and greater internal and external rotation of the knee increases the risk of injury. The Achilles tendon is a large, thick tendon located on the posterior side of the distal leg that connects the calf muscles, which are the gastrocnemius and soleus, to the heel, which is the calcaneus bone. When the gastrocnemius and soleus muscles are contracted, a force is moved through the Achilles tendon, which causes plantar flexion of the foot. This allows for propulsion through the lower limbs, allowing the body to move in activities such as walking, jumping, and running. These activities create higher strain on the Achilles tendon with loads of up to 10 times the body weight. The Achilles tendon is made of collagen and elastin, allowing it to be both strong and flexible. The fibers are spiralized as the tendon turns 90 degrees medially on the descent to the heel. This spiralization allows for increased strength and greater force transmission. The Achilles tendon is surrounded by a paratenon rather than a true synovial sheath. The paratenon is made of loose connective tissues that surround the tendon, allowing for reduced friction and smooth movement. The paratenon can stretch 2 to 3 centimeters during movement to allow for the largest possible gliding action. Achilles tendinopathy is an injury of the Achilles tendon characterized by pain, impaired performance, and swelling. This is due to a failed healing response, the degeneration of tenocytes, and an increase of non-collagenous matrix. This can be seen as unequal and irregular crimping, loosening, and increased waviness of collagen fibers. Achilles tendinopathy accounts for 6 to 17% of all running injuries. It is common to feel pain or stiffness after a period of inactivity and a progressive onset throughout physical activity. It has been suggested that the main cause of Achilles tendinopathy is repetitive tendon overload during intense and demanding activities, including running. However, the exact etiology remains unknown. Even within the physical limit of the tendon, repetitive strain can lead to minor injury, which, if not completely healed, can lead to tendinopathy. Other intrinsic and extrinsic factors that can lead to the development of Achilles tendinopathy include age, gender, weight, increased intensity or sudden change in training, poor technique, uneven or slippery training surface, weakness and lack of flexibility of the gastrocnemius and soleus muscles, and lateral ankle instability. Achilles tendinopathy affects normal running due to increased pain, stiffness, and swelling in the tendon. This may make it harder to push off the ground during the takeoff phase of running and reduce the overall load the tendon can withstand. Reduced muscle activity was found during the heel strike phase for runners with Achilles tendinopathy, which may reflect the inability to withstand higher loads and also demonstrates the presence of pain in the tendon. It was also found that runners may shift load from the lower leg and ankle to the proximal hip in order to reduce the load on the Achilles tendon. Runners experiencing Achilles tendinopathy may need to reduce the length of time spent running, take longer breaks, or swap to lower impact training such as swimming. In conclusion, throughout this presentation, we have explored the running technique first through body segments in sagittal and frontal views. These images show the importance of flexion and extension of the arms and legs through the elbow, hip, knee, and ankle joints throughout the entirety of the running movement. Another key movement that was explained was the contralateral rotation of the pelvis and hips as they move in opposite directions throughout the movement. Similarly, the arms and legs also move in opposite directions, with each arm following the direction of the opposite leg. Finally, plantar and dorsiflexion of the foot are essential in the takeoff and landing phase of the running movement. Directional terminology is important in biomechanical application because it enables clear and precise communication around the location, position, and movement of different body structures, which is vital for prevention, diagnosis, and treatment of injury. Through directional terminology, health professionals are able to identify incorrect movement patterns and develop plans and strategies to prevent further injury. Listed above are my references used throughout this presentation. Thank you for watching.